So we'll be starting with myofunctional appliances. These are the contents. You'll be going over introduction, the evolution, mode of action, theories and hypothesis, theories or hypothesis, functional appliances, mandibular growth and conclusion. So coming to introduction, functional appliances are those appliances that elicit the natural function of the orificial musculature and causes a change in effects of the structure. So myofunctional appliances are those which harness the muscle pressure to their advantage and thereby affecting the tooth movement. So it can also be where the myofunctional appliances are used to eliminate certain forces that are not desirable in orthodontics. So by definition, Prophet he gave the definition by functional appliance is one that changes the posture of the mandible, holding it open and forward, and pressure created by the stretch of the muscles and the soft tissue is transmitted to the dental and the skeletal structures, moving the teeth and modifying the growth ultimately. Moyes he explained that the myofunctional appliance is a loose removable appliance designed to alter the neuromuscular environment of the orofacial region to improve occlusal development and or craniofacial skeletal growth. So, in the last 20 years, functional appliance therapy has become generally an accepted method to treat severe and moderate cases of sagittal jaw relation in children. So, until now, the functional appliance therapy has had its greatest application and success in class 2 maloperations, particularly. So right now there are a variety of different function appliances that are available. The appliances that are selected for the treatment can be adapted to the type of anomaly and to the growth pattern. So the growth direction, the amount of growth, the timing are relevant to the ultimate success of the treatment. So the goal here is to shift the mandible to provoke a phenomenon of the bone and the cartilage remodeling that would change its structure and the position. And the myofunctional therapy goal is to correct the neuromuscular imbalances, to reactivate the torn out efficient muscle groups, and to block on or weaken the negative action of other predominant ones. So here the concept is that you to achieve a good stable relation between the skeletal structures and the muscles, there should be a proper balance between the either of them. So to maintain that, that's where the concept of the myofunctional therapy comes. So, on theoretical basis of the functional treatment, the new pattern of the function is when the new pattern of the function is elicited, or for example, in this case, you're bringing in a class 2 case, you're bringing the more mandibular forward. In that case, a new pattern of function is created because the patient has to bite forward, close forward, or even when he's articulating, as in a speech, he has to. Open and close in that new pattern, which creates a new morphological pattern at the end of the day. So the morphological pattern that means is that so the new pattern of function can be the different functional component of the orofacial system, such as the tongue, lip, facial, masticating muscle, ligament, and the periosteum. So any changes, any new pattern of, say, you're giving habit breaking appliance to a tongue thrusting patient, the tongue is reprogrammed, a new pattern of function is made. So because of such things, there'll be a cause, the effect will be a new morphological pattern created. So different arrangement of the teeth within the jaw, and improvement of the jaw occlusion, and the altered relation of the jaw. So it also includes the changes in the amount and the direction of the growth of the jaws, and the differences in the facial size and the properties. So mode of action of the functional appliances. So primarily, you have various forces that are acting on the dentition by the tongue, lip, and cheeks. For example, on the lower anteriors, you would have tongue which is exerting force through the lingual side, and on the facial side, it is the lips that is exerting force on the center incisors, which ultimately the forces between these two ultimately leads the central incisors to erupt in its optimal or ideal location. So, for example, in case where the lip is hyperactive or it's providing more pressure on the lower incisors, which ultimately leads to the eruption of the lower incisors in a such a way that it's retroclined or it pushes the upper incisors labially. So, in that case, where you need to prevent this excessive force from the lip, what you give is a lip bumper. So, what lip bumper does is it acts on the principle of the force elimination. So, you're eliminating the lip force on the incisors by giving such an appliance. Now coming to the characteristics of the forces produced by the appliances. So it can be either force application or force elimination, as I said. So force application could be compressive stress and strain acting on the structures that are involved and resulting in a primary alteration with secondary adaptation of the function. Whereas force elimination would be then abnormal or restrictive environmental influences are eliminated using certain appliances. So coming to theory, you have the muscular hypothesis, viscoelastic hypothesis, functional matrix hypothesis, and the growth relativity hypothesis. So coming to the muscular hypothesis, here the case is that the muscular functional component will seem to always have an important influence on mandibular growth, both naturally and also when it is influenced by an appliance that you are giving to the patient. So Rees in 1952, he said that the lateral pterygoid muscle, the deep mesenteric muscle, temporalis muscles, which are attached to the articular disc and are because you're giving a new position in the mandible, there is a stretch in these muscles. So because of that, there is a causative condylar growth at that point. Grood in 1952, he said that the such adaptations which are possible with small bite opening that is within the physiological rest position, which means your mouth opening at the ideal state. So it will be vertical opening, vertical distance at occlusion, that is video minus VDR, which is vertical distance at rest. So McNamara, Petrovic, and Stutzman in 1970s and 1980s, they said that the correlation between the condylar growth and the lateral pterygoid muscle hyperactivity was constant finding in animal studies, which they had concluded. We'll be explaining that in further, which is in 1990, Stutzman and Petrovic, they said after the surgical resection of the lateral pterygoid muscle in a growing rat, there was a decrease in the growing cartilage that was observed. So, a electromyographic record of the lateral pterygoid muscle in the monkeys have shown that there is an increased electrical activity, which says that there are certain changes that are going on at a cellular or cellular ionic level. So, in an experimental study, the lateral pterygoid muscle was directly stimulated by the means of intermittent electric shocks that had a frequency of 5 minutes per second. So, it was an intermittent shocks that were given to the lateral pterygoid muscle directly that produced an increased rate of condylar cartilage growth. After the treatment with the postural hyperpropulsor, that means the mandible was brought forward, the condyle is stretched, there is a significant increase in the proportion of the fast, non-fatigable fibers that were noticed in a rat's LPM. So filling in tension zone. So the concept is wherever there is a stretch in the muscle or stretching activity is going on, the osteoblastic activity increases at that point, and then the matrix is laid and new bone formation occurs. So thereby there is a growth of the condylar cartilage, and thereby remodeling of the condyle ultimately happens. So to accommodate the new position of the condyle, the glenoid fossa also undergoes remodeling. Viscoelastic hypothesis given by Heron, Harwell, and Woodside in 1973. They said, as I already explained, the stretch of the retrodiscal tissue induces a new bone formation because there is a stretch, there is infiltration of the osteoblast at that point, and there is a new bone formation at the condyle. Functional matrix hypothesis given by Melvin L. Moss. He had a set of three articles that he published 1962, 1969, 1997, all of which emphasize the length of the mandible depends on the size of the oral capsule. Functional regulator, which is used for growth modification. So active muscular component is actually proprioception. Proprioception is what you can touch. or what a touch or the pressure where you can locate, even in case if you get a pain at a part of your body, your brain can pinpoint that location. So that is your proprioception. So viscoelastic hypothesis, periosteal stretch by the lip pads and the buccal shield will prevent unnecessary force acting on the dentition and screening of the deleterious forces. That is the principle of force elimination. Growth relativity hypothesis. Wooders and Koftenek in 2000, they gave that the growth relativity refers to the growth relative to the displaced condyle from actively relocating the fossa. So there is no role of muscles for the growth modification. So the main foundation of hypothesis are that is the displacement of the condyle because a new configuration has happened. A non-muscular viscoelastic tissue stretch is there. That is the retrodiscal tissue. The force transduction beneath the fibrocartilage of the condyle and the glenoid fossa will add a new bone formation to the condyle and as well as the glenoid fossa. So this would be the whole picture representing that the retrodiscal tissues are being pulled apart, and that's why there is retrodiscal tissue forces. The fibrous capsules are also being pulled apart, so the forces are acting there also, and there is perfusion into these areas by the synovial fluid. And wherever there is force transduction going on, there is a new bone formation at that point. So by conclusion, Enloe and Hans in 1996 and 2001 suggested that the mandible grows under the influence of all these variables, that is the teaching of forces and the functional agents of growth control, and therefore control the growth cannot be attributed to any one particular variable.